Assalamu alaikum viewers. Welcome to VTeach24.
Myself, Dr. GhulamUllah Lail, Assistant Professor Medicine and Allied. So today we are going to discuss the lower GI bleeding, in which we will discuss the diagnostic approach towards a patient we have seen and discussed in earlier in the when we have discussed the upper GI bleed. So now we will discuss the lower GI bleed, the diagnostic as well as the therapeutic modalities that we will be using in the patients with the lower GI bleeding. Lower GI bleeding generally signifies the bleeding from the colon or the anorectum. The annual incidence of the lower GI bleeding is approximately 20 cases per 100,000 population and is increased risk in the older adults. So as the age grows, there are the chances of the different diseases that can present with the lower GI bleeding, which includes the angiodysplasia, the hemorrhoidal diseases, and so on. So patient usually presents with painless hematochezia and a decrease in the hematocrit value but without orthostasis. Orthostasis means the orthostatic hypotension that the patient develops in usual cases in the upper GI bleeding. Upper GI bleeding, if that is severe, that can also present with hematochezia. What is hematochezia? Hematochezia is a fresh bright red blood passage rectally. So even the upper GI bleed can present with hematochezia, but most of the times painless hematochezia is secondary to the lower GI bleeding, and you can see the difference between the two, the upper GI bleed and the lower GI bleed. If the hematochezia is secondary to the upper GI bleeding, that patient will present with the orthostatic hypotension or the orthostasis. If orthostasis is associated with hematochezia, a brisk read upper GI bleed, so the upper GI bleeding should be excluded if there is orthostatic hypotension or the orthostasis. Severe painless hematochezia results from the foregut in approximately 15% of the patients. If 100 patients are presenting to you with the hematochezia, 15 will have upper GI bleed. So every patient whosoever presents to you in your clinic with hematochezia as well as the orthostasis, then you'll do the upper GI bleed, rule out the upper GI bleed. So the origin of the GI tract bleeding for the severe hematochezia depends upon the characteristic points, but what are the different sites? Almost 5% of the site is from the small intestine, and up to 15 to 20% from the upper GI tract. More than 3/4 is secondary from the colon. So the hematochezia, the major cause will be the bleeding from the colon, and any other bleeding except the hematochezia, that is fresh bleeding, blood mixed with the stools, is lower GI bleeding. And diagnostic approaches and the therapeutic approaches, initially we will be going forward in a direction that we will discuss both the angles of the diagnosis as well as the therapeutic from the different perspective. Definitely whenever we are receiving patient in the emergency department, we used to perform the vital signs, which includes the blood pressure, pulse, temperature, and the respiratory rate. Blood pressure, definitely if you are taking the blood pressure, you will see if there is orthostatic hypotension or not, if there is hypotension or not. If there is hypotension, then definitely even in the presence of the fresh bright red blood rectally, you will go for the upper GI endoscopic intervention to see if the cause is from the upper GI tract. But and all those the upper GI endoscopy, CT angiography, or the RBC tag scanning that are the part of the upper GI endoscope may be used in the patients when there is some chance to have the bleeding from that side. But for colon, you have the options flexible sigmoidoscopy, colonoscopy, and then the CT angiography if needed, or the technetium scannings. Flexible sigmoidoscopy evaluates the rectum and the left of the colon for the bleeding side. Flexible sigmoidoscopy can be used in patients suspected of having the solitary rectal ulcer, ulcerative colitis, radiation proctitis, ischemic colitis, or the polypectomy bleeding, or even the internal hemorrhoids. So these are the major causes of those bleeding within the gut or the lower GI bleeding. These all are the causes of the lower GI bleeding, and one of the lower GI bleeding cause is the malignancy or the colorectal carcinoma. But the colorectal carcinoma usually presents with the slight bleeding, is usually not presenting with the massive bleed or the. And what therapeutic interventions we'll have from the flexible sigmoidoscopy? Either the injection therapy, hemoclip deployment or hemoclip deployment, band ligation for the internal hemorrhoids, or the monopolar electrocautery, that is with the organ plasma coagulation, snare polypectomy, or the heart. You can also use the heart biopsy forceps. These all are the therapeutic interventions that we can offer to the patient by the flexible sigmoidoscopy. These all can also be used in the colonoscopy. The only difference between the flexible sigmoidoscopy and colonoscopy is the extent of the examination. Colonoscopy, we usually perform colonoscopy in the older adults or the elderly, those who are having more chances of the colonoscopy or to reveal the right-sided colon malignancy, right-sided any lesion that can lead to the bleeding. So sigmoid, and you can also use the radionuclide imaging. Radionuclide imaging involves injecting a radiolabeled substance into the patient's bloodstream and performing a serial scintigraphy to detect the focal collection of the radiolabeled material. This technique has been reported to detect the bleeding rate as low as 0.04 ml per minute, and with an overall positive predictive value is 45 and an accuracy rate of 78% for localizing the true bleeding site. Radionuclide imaging is usually not preferred, is not in the initial test to be performed. Initial test we used to perform is either the flex sigmoidoscopy or colonoscopy, and if needed, and if the bleeding source has not been identified, we can go for the radionuclide imagings. The disadvantage of the radionuclide imaging is delayed scans may be misleading because the bleeding is in the small intestine but the blood is passed into the colon, and delayed image shows the focus within the colon. We can misinterpret, so misleading. And determine the specific cause of bleeding is often depends upon the endoscopy or surgery. And the other point, because blood moves with the peristalsis forward, and we'll see the focus, the point may not be the real point, and the specific cause, what is the cause, why it is the bleeding is happening, will depend upon the endoscopy. As we have seen in the earlier slides, the different lesions that can bleed, like the solitary rectal ulcer, ulcerative colitis, radiation colitis, proctitis, ischemic colitis, or the post-polypectomy or internal hemorrhoids. What is the probable cause of the bleeding? The radionuclide imaging is not going to give us clue about that. So this is why the flexible sigmoidoscopy or the colonoscopy is preferred.